Okay, so I'm Arjuna. Nice to meet you all. I'm the consultant neurophysiologist. As Deepa said before, if for any reason I'm too quiet, just put your hands up. I'll speak a bit louder. Okay, so many of you may have seen some of these slides if you were in our patient day talks in the last couple of years. So probably most, if not all of you, will have had some neurophysiology as part of your testing when you were initially diagnosed. Neurophysiology is essentially how we look at the function of nerves and muscles, as opposed to, for example, radiology and scans where you look at the structure of nerves, muscles, and other things. The testing we used to do and what we have done up till now has primarily focused on using electrical pulses and a small needle to assess nerve and muscle activity. There are also specific tests called exercise tests that allow us to bring out the behavior of muscle and differentiate between different channelopathies. The short exercise test is what we use preferentially for myotonic disorders, so people with non-dystrophic myotonia, and can let us categorize people. The long exercise test is a different kind of exercise test. The protocol is different. We get you to do a little bit more exercise with your hands. And that brings out a particular abnormality for patients who have periodic paralysis. And these are very robust tests. They've been tested quite a lot on large numbers of patients. They work very well, but they are not perfect. Some of the issues with them include that if your disease is mild or if your attacks are very infrequent, the testing can come back as normal. And that, of course, might have an implication in delaying the diagnosis. The other thing is exercise tests rely on the patient yourselves being able to cooperate very well with the test and being able to obey instructions quite quickly. And occasionally, we don't usually have a problem, but occasionally that can be troublesome. It means also that we're unable to assess patients who are unconscious if they happen to be on, let's say, intensive care. And the other thing is, particularly with the long exercise test, the test is quite time-consuming. This is just, so many of you will be familiar with this sound. Hopefully we've got a... So just to explain that briefly. So when you put a needle into your muscle at rest, if you're not doing anything, the muscle should be silent, okay? When you move the muscle we have the needle in, you will get some activity, okay? You'll get some various spikes coming up. In people who have myotonia, you can sort of think about it in the sense that your muscle is hyperexcitable or overly jumpy, okay? And what you see when we put the needle in at rest is that it should be silent, but actually you get these sort of pings coming up, okay? And that's the muscle, basically, we're able to express that it's more jumpy than it should be. So there is a newer technique called muscle excitability studies, and it relies on a specialist software that we use. It still uses a lot of electrical pulses, and actually the software that we're using for this, or that can be used for this, is something we are already using for people who have overexcitable nerves. I'm not sure if we have any patients here today with nerve excitability disorders. No. As I said, the way the test works is similar to exercise tests in the sense that it is a lot of electric pulses given as a protocol in fast succession. The purpose is that, what we have found is that these new techniques are able to actually differentiate, potentially, between people with myotonia and periodic paralysis as well. And sort of be able to demonstrate whether the muscle itself is overactive or underactive and so on. And it is a promising technique. One of the things to say is that when we do our normal studies, our nerve conduction studies in EMG, although they work very well, actually they're an impure assessment when your problem is actually solely in the muscle. So in people who have channelopathies, the problem is a very pure problem, and the weakness or symptoms that you're getting is because of its function purely limited to the muscle. And actually this technique is better at separating out muscle activity by itself rather than looking at what is essentially a compound of nerve and muscle activity. And we do have some evidence in studies on animals and in other human tests that they are helpful at differentiating between different disorders. And it's actually improving our understanding of these conditions. And this is what it looks like. So we've got two very small needles, similar to the ones we already use for EMG, and a couple of electrode tabs there, which we stick on your skin, which pick up the signal from your muscle. It's mostly painless. Obviously, when the initial needle goes in, there's a small amount of pain. But other than that, you don't really feel much. It doesn't depend so much on cooperation, so it's good in people who are, say, sedated, on intensive care, if they're drowsy, if they have difficulties cooperating for any other reason. And broadly speaking, as I said, what we're using are electric pulses and a small needle, so it's nothing sort of new from that perspective. And we do have a pilot study we are planning in collaboration with Dr Sutherland, who's a neurophysiologist in Newcastle. We're currently waiting for the ethics to come through to let us start that on select patients. The reason we're doing it is that if it is successful and if we can demonstrate that actually we can get the same usefulness out of the test, it will help us reduce the time it takes in clinic and therefore be able to see more patients. It can potentially increase the sensitivity and mean that maybe we can pick up some of these cases where we're missing them at the moment, particularly in people where your disease is milder. And the aim of all of that is really to hopefully help delay or reduce the delay to diagnosis.